My mouse is struggling this evening. This is Dr. Kukreja. He started Minimally Invasive Surgical Associates here in Dallas in 2016. As you can see, he's been busy before and since, going to medical school at the University of Texas in San Antonio, and did his surgery training in Chicago at Rush and Cook County, followed by a fellowship at the Medical College of Wisconsin. He's been the director of bariatric surgery at multiple hospitals and is the medical director of metabolism and nutrition at Methodist Dallas. In addition, Dr. Kukreja is very involved in national presentations and publications and actively involved in resident and surgeon education, as well as serving as an opinion leader and a proctor for Intuitive Surgical. Of course, he's board certified in general surgery and fellowship trained in bariatric surgery, and he's also board certified in obesity medicine. This is me. I'm Dr. Elizabeth Hooper. I went to medical school just north of here in Oklahoma, the University of Oklahoma, and then Dr. Kukreja and I crossed paths during our training in Chicago. We overlapped for a couple of years and became friends and colleagues since. I did my bariatric fellowship in Boston at Tufts Medical Center in 2012, 2013. And then for the last 7 years, I worked in Oklahoma City as a bariatric and general surgeon. I, of course, am also certified in general surgery and fellowship trained in bariatric surgery, working on those obesity medicine boards, and we'll have that ready to add to the list in the next couple of months, next time I can take that test. I joined the practice here in Dallas this fall. So where do we operate? Now that you know who we are a little bit, we operate at multiple places throughout the Dallas area, and we do that so that we can fit what's based on your insurance plan and where we have the proper resources to take care of each patient. So we operate at Methodist, Medical City, Texas Health Presbyterian, City Hospital, and a few others if need be. Well, what makes us different? Here's Dr. Kukreja with one of our patients. We like to say that we're not a factory. We don't do the same surgery for every patient because they're not always the same. There are a lot of specific health factors and needs for each patient that we need to discuss and learn about so that you make the best surgical decision for yourself. In addition to treating each patient in the unique manner that they are, we also teach residents and students, we mentor other physicians, write and present our data throughout the country. Let's talk a little bit about why we do what we do. So the health problems of obesity, these are just to name a few. So when someone has a weight problem, especially as that weight gets higher and higher, we start to see other medical problems like diabetes, high blood pressure, sleep apnea. We can also see problems like asthma, venous stasis or swelling in the legs, or hormonal problems like PCOS. This is where we really get into the why. We start to see benefits in all of those things we listed on the previous page, like um, type 2 diabetes on average 83% resolution, high cholesterol 63% resolution. Quality of life for patients, 95% of our patients see an improvement in their quality of life and an 89% reduction, 89, that's a lot, in 5-year mortality. In fact, the New England Journal of Medicine published an article about long-term mortality after gastric bypass surgery. I won't read the whole article, but the basics are that people who didn't have weight loss surgery with a BMI greater than 45 were dying at a higher rate than the people who either had a lower BMI or who'd had surgery um, over time. And so they followed people for 16 years in this study. Medical weight loss is certainly an avenue that people can pursue to lose weight. What we know, though, is that medical weight loss on its own is very difficult. And so we can look at some of the data for that. So The green is diet, which you can't even hardly see because the behavioral therapy really overlaps that pretty well. When you combine both, you get a little bit better weight loss. So we see that the weight starts at 0. We get a drop in about 30 pounds. And then over time, it starts to go back up. And I think a lot of people that are coming to see us about weight loss surgeries have this experience. They've had a really intense diet and behavioral intervention where they've had some success, and then over time their weight goes up. And we see that over and over again. When we're looking at weight, one of the ways we can compare weight versus height is called the body mass index. And this is where a lot of the medical literature comes from on when you need to, uh-oh, someone says they're not seeing my slides. Okay, thank you. Let me try to reshare them. Are you seeing my face? Let's see. Okay, let's try this. How about now? Can you see it now? I'm waiting to see if they answer. Awesome. Thanks for letting me know. Okay, so when we're looking at weight, one of the ways we can measure that is with the body mass index, which relates weight and height. And there's two ways you can look at that. We can look at height and then follow over to find someone's weight and see which category they fall into. Or we can look at it in a more graphical representation where we can find that number, and then these kind of correlate to body shape, not exact. The more we move towards the left of this screen, the more likely we are to see those medical problems that we had listed a few slides ago. We're going to talk briefly about non-surgical procedures, which we do offer in our office as well. On the next slide or two up, I've got a couple of videos from the procedure. So if you're a little squeamish, I just want you to know about that. So non-surgical procedures are not covered by insurance. They're cash-based procedures. And the two that we do in the office are Orbera, which is a balloon. We place this balloon into the stomach and fill it with fluid and then take this tube out. We do that under the vision of an endoscope, so like having an endoscopy. These have actually been around for a long time in Europe and South America for 20 plus years, well over 500,000 implants with a very good safety profile. In the US, when they got FDA approved, they had about a 15% early extraction rate. Some of that data looks to be because they weren't giving much in the way of nausea medicine, which we're very aggressive with for these patients. This is a 6-month program where the balloon stays in for 6 months and then it is removed with another endoscopy. Early on, patients certainly have some nausea and potentially vomiting issues. This is the video of the endoscopic sleeve gastroplasty. Some people call this the accordion procedure. What we're doing here, and I think the best video is, first you can see the little needle moving in this first picture, and we grab the stomach wall and then put that needle through. And this purple is our stitch. And as we make our stitch move from spot to spot, what we're doing is actually folding and gathering the stomach in to narrow the stomach. So what you end up with is this tubular area, and it's much smaller. It can't expand as much. So endoscopic sleeve gastroplasties also are considered non-surgical, but this is permanent because that stitch we use is designed to stay there forever. There's really only 5-year data available at this point. We see about 20% of total body weight loss, low potential risk of injuries, and the primary feeling is that patients feel fuller faster, so they eat smaller volumes. Surgical weight loss is what we mostly concentrate on here in our office. Here's Dr. Kukreja hard at work in the operating room. He is getting the robotic instruments placed and set up. And we do this surgery with the robotic instruments. Occasionally we use laparoscopic instruments, so very similar, small incisions on the abdominal wall and long instruments so that we can work inside. So here's some videos of robotic surgery. On the right picture, you can see Dr. Kukreja's hands. He is moving those instruments. So he is pinching with his fingers to move the tip of the instruments. We can turn like our wrist and make the tip of the instrument turn. We can push in and move the instrument in or pull back. And so he's really doing some big movements here so you can really see those little arms moving on the outside. It's a little bit more delicate in real time. So what surgeries are we doing with those robotic instruments? We do sleeve gastrectomies, gastric bypass, and duodenal switch. We're going to talk about each of the three now. Sleeve gastrectomies, these patients are usually in the hospital for one night. It's about an hour-long procedure. We remove about 2/3 of the stomach and leave behind a banana-shaped tube. So in this picture, this brighter pink is going to be what stays. The light pink is what goes. We see about 60% of excess weight loss and about 60% of diabetes resolution. There's no malabsorption, which means what you put in, you should be able to absorb. And then primary effects are that you restrict what goes in, and then there's a hunger hormone called ghrelin, which we see less of after this surgery. Problems after this surgery are rare, things like leaks or heartburn. 10-year data is out that shows that 60% resolution of diabetes and 60% excess weight loss. Because people are eating a smaller amount, they do need to take a multivitamin and a calcium daily. This is a surgery that can be revised if there are any issues or concerns. The next is the Roux-en-Y gastric bypass. So this is considered the gold standard, the surgery that's been happening since the 1960s. When we do this with the robotic instruments, it takes about an hour and a half, and we see about 70% of excess weight is lost and about 70% diabetes resolution is noted. The stomach is separated into two parts. So we have a gastric pouch, it's about the size of an egg, and then the remainder of the stomach is left behind but does not get food towards it. And then we make a new connection in the small intestine as well. And this first part of the stomach to the small intestine is the bypassed portion. This is considered irreversible surgery. Again, rates of problems after surgery are very low. Things like leaks or internal hernias are both less than 1%. Ulcers, 1 to 2% over lifetime. Vitamin deficiency is low, but still very important for patients to take a daily multivitamin and calcium. And then we can see dumping syndrome. Dumping syndrome means that sugars in the diet get absorbed faster, and they can make people have cramping or sweating or maybe some diarrhea. So it's important to work with the dietitian both before surgery and to maintain those changes after surgery to prevent dumping syndrome. Duodenal switch is the third of those operations that we showed. This is considered the most aggressive of the operations, and we usually see about 80 to 90% of excess weight loss and about 90% diabetes resolution. These patients are the least likely to have weight regain over time, and their weight loss continues over about 2 years. The surgery is a little bit more complicated, so it's a little longer in the operating room. And because of the way we change the connections in the small intestine, it's absolutely required that patients take a special vitamin with fat-soluble vitamins, and those are A, D, E, and K. Those are vitamins we sell here in the office to make sure patients have access to a good quality vitamin. Again, rates of problems with surgery are very low, less than 1%. More common issues that patients can have may be complaints of farting a little more or flatulence or diarrhea, especially if they eat more fatty foods because they don't have time to absorb that as much. And that's also why the fat-soluble vitamins can be at risk. There's not as much time to absorb them. So vitamin compliance is absolutely imperative with a duodenal switch. We do offer revisional surgeries as well for patients who've had lap bands that may have difficulty swallowing or failed weight loss. Sleeve gastrectomy patients may have trouble with reflux or again failed weight loss. Gastric bypass, failed weight loss, or ulcers. Sorry, this time change is getting me still. Okay, so let's talk about revisional surgeries. So lap bands, they can be removed and then converted to a sleeve or a bypass. That's usually done in 2 stages, meaning we remove it and then a few weeks to a few months later, we go back and do the second part of the operation. That allows for some inflammation from that previous band to resolve and improve. Sleeve gastrectomy can be converted over to a gastric bypass. We tend to do that for someone who's having problems with heartburn or reflux. Or we can consider going to a duodenal switch for someone who is having failed weight loss. With gastric bypass, we can make the bypass portion of the intestine move further down or revise the pouch, or it can be converted to a duodenal switch where we basically have to put everything back together and then do a duodenal switch. So what does this process look like? How do we go from learning about it to getting ready for surgery? Well, everyone's insurance plan can be a little bit different. So some insurance plans require medically supervised weight loss, and they may have a certain number of visits over time. They may say it has to be 3 months consecutive or 3 visits in the last 6 months. It can vary widely. Um, Patients also are required to have a mental health evaluation. This is really to help us know and understand, and for patients to prepare themselves for the mental change aspect of really changing the way they eat and interact with food from this point forward. And then many insurances require that your primary care physician documents the benefit of weight loss surgery, that this will improve your overall health. In addition to that, we require patients to participate in a hospital-based class. We use the Weight Management Institute at Methodist Hospital for diet for teaching, and there are also support groups through the Weight Management Institute as well. Um, Occasionally, patients will have surgery not at that hospital, but we have everyone go there. Um, in addition to getting that additional teaching and training from the hospital-based class, we may ask patients to see a heart doctor, a lung doctor, a GI doctor, or do additional testing like a stress test or an upper GI. We do also have all of our patients meet with dietitians. So what is the data for all of this? Bariatric surgery is really well studied, it's well documented and followed at each hospital, and then all that data can get pulled together into this national database. So we utilize this when we're talking to patients before they're making their surgery decisions. So we can look at someone's risk factors and talk about their specific potential risks. So for example, this patient has a BMI of 41, age of 40, they're female, and they have systemic disease. So they have non-insulin diabetes and hypertension. This is a pretty common patient scenario for us. So what we see is red is sleeve, blue is bypass, and yellow is duodenal switch. So for risks like death, very, very low, way less than, 0.01 to 0.02%. Any complication a little higher with each surgery, but this is the national data, and our data in our practice is actually about half as high. So, that'd be any complication for a duodenal switch around 4%. That could be anything from like a little infection or coming to the hospital for IV fluids or bleeding or leaks. So all of these numbers are very low and less than 1% for the leaks, bleeds, surgical site infections for us. This is where we kind of get that 60%, 70%, 90% data. So again, our sample patient had a BMI of 40, and here they are at 1 month after surgery. And then as we follow down the sleeve at a year out, they're at about 60 pounds down. With a bypass, they're at about 70 to 75 pounds down. And with a duodenal switch, they're at about 93 pounds down. So hopefully that helps bring those numbers out. This data shows likelihood of readmissions. Oh no, I'm sorry. Likelihood of resolution after surgery. So high blood pressure, 50%, and then it goes up as each surgery goes along. Diabetes resolution, um, well over 50% for all 3 procedures. So what about the recovery? Well, we use 5 small incisions to do the operation. Most patients stay in the hospital regardless of the procedure for 1 night. They tend to have some incisional pain, usually taken care of by Tylenol for 4 or 5 days. And only about 15% of our patients need narcotics. We progress the diet along very slowly so that we can allow for time to heal the inside where we've made those cuts and rearrange the intestines or where we've cut the stomach with the sleeve. So these are all tools to help patients achieve their ultimate goal and to make change in their life. There are responsibilities on both sides to help get ready for surgery. So we want to help you through that process in a non-judgmental way. We have office staff that is going to help you stay in the loop and understand what the next steps in your process are. And again, that can vary a little bit based on your insurance. Speaking of insurance, we always want patients to take it upon themselves to also verify their insurance and to understand what your benefits are. As you're working through your steps and your testing or seeing the dietitian or those different requirements for your insurance, we want to know when you've met another task on the list. Some patients do not have insurance coverage, and we do have some self-pay options for patients, including some financing options outside of the office to help pay for surgical intervention. We always want to encourage patients to enlist the support of friends or family. Um, Join our Facebook group. Verifying insurance on your side and our side, of course, is very important. And then we want you to enlist us. Let us be part of your team to help you along this process as you become healthier. Here's a little screenshot of our website, Minimally Invasive Surgical Associates, MISA Dallas.com. And here is our office on that big red dot just west of downtown Dallas. Couple more info shots for you here. MISA Dallas, that's our website, phone number, and then on social media under Sachin Kukreja, MD. Okay, that is it for tonight. So at this time, if you guys want to use the chat function, you can definitely do chat or you can do Q&A and shoot me some questions and let's see what people are asking. Okay, I've got a couple questions over on Facebook. So patient had gastric surgery and a hernia repair 3 years ago, have a hard time swallowing off and on. Is that normal? That can be normal, but it does not, it's not always normal. It can depend on how often you're having that problem and if it's with certain types of foods. So it might be something that's worth checking into. And got another question over here. Which MD works out of Medical City? We actually both work at Medical City. So we both have privileges there and do operations there regularly. What other questions do people have tonight? Um, which Medical City location? That's a good question. We're at the Medical City Dallas location. So 635 and Coit Road. So some of the common questions that we get when people are thinking about weight loss surgery is, what is the diet like around the time of surgery? We ask patients to follow a low calorie, high protein diet before surgery for 2 weeks. The specific reason we do that mostly liquid diet is that we want patients to get their body into fat burning mode. And specifically, when we burn that fat with that type of diet, we're going to pull some of it out of the liver. The liver lays right on top of the stomach. So if we can make that liver smaller, it's about 18% smaller on average, then we can do this surgery more safely and more efficiently. And it gets patients jump started on that fat burning for after surgery. After surgery, patients stay on a liquid diet for another 2 weeks, and that allows that pouch and new intestinal connection to heal when we're talking about gastric bypass, or the sleeve to heal with a sleeve gastrectomy. After that, patients slowly advance their diet over the next couple of weeks as they continue to lose weight. Okay, I'm looking for what's the recovery time for these procedures? Great question. So most patients are in the hospital for 1 night. I generally recommend that patients plan to take at least a week off of work. They should be feeling really pretty good by that time, but we want to really make sure they're staying hydrated. And so that first week after surgery, while you're at home, recuperating, relaxing, but up and moving and walking around, we do want you to be getting all your fluids in. Okay, this is a great question. So thinking about ESG, so endoscopic sleeve gastroplasty, what BMI range does that fall into? That's really only indicated for a BMI between 30 and 40. Because any BMI over 40, we tend to not see enough weight loss to make a significant change in medical problems. So for BMI over 40, we recommend going to a more robust procedure like sleeve or gastric bypass. I have another question. Can my spouse stay with me at the hospital the night of surgery? That is a question that seems to be changing daily. And in fact, I don't know what today's answer is. So historically in the past, people have always been able to have someone stay with them overnight. The hospital has gone through various iterations of no visitors at all, one visitor, certain visiting hours. I think that's difficult because I think it's just very subject to change. So I'm going to say I can't answer that question tonight. Uh, and it may be that it changes to yes or no the day of your surgery or the day after. What I do know is that our nurses are fantastic and are taking great care of our patients throughout this pandemic, so that our surgical patients are safe and well cared for and ready to go home that next day. Hopefully that kind of answers your question. Okay, next question. Did you mention that VSG is reversible? How so if half the stomach is removed? Um, Vertical sleeve gastrectomy is not reversible. And if I said that, that was a, what do you call it when it's a live action typo? Um, a, uh, that was not what I meant to say. So vertical sleeve gastrectomy is not considered reversible. Okay, got another question off of Facebook. Can we ever drink coffee again? Um, we generally discourage patients from drinking caffeinated beverages. There's a couple reasons for that. Caffeine can actually cause you to be a little dehydrated, and so we want to make sure you are well hydrated after surgery. Caffeine also can be kind of a slippery slope for some people. It may get them back to drinking Coke or Pepsi where they're having more bubbles. There's really not room in the stomach for those things after, after weight loss surgery. Looking to see if there's other questions. I would say there are some people who will drink, you know, a cup of half caffeinated coffee per day when they're out further from their surgery. If you drink your coffee with 7 tablespoons of sugar and a bunch of heavy cream, I would still discourage that after surgery. Okay. Got another good question about diet. What about a vegan or vegetarian diet post-sleeve gastrectomy? Generally, we encourage patients to be on a higher protein, lower carbohydrate diet because protein takes a little bit longer to digest and absorb and helps people feel full a little bit longer. But certainly there are patients who've had weight loss surgery who are vegan and vegetarian. It definitely takes a little bit more practice and education and training so that you're getting good protein sources from your vegetables. While minimizing simple sugars and carbs and making sure there's good fiber source. Some vegetables actually are a little bit harder for people to digest when they've had changes in their digestive system. So definitely have to be adventurous and like all vegetables if you go a more vegan or vegetarian route. But for most patients after weight loss surgery, they actually go with a higher protein, lower carbohydrate diet. Okay, someone's asking about um, going home the next day. Well, we have criteria on how much fluid patients need to be drinking. They need to be up walking, their pain is controlled. So we don't send people home until they're meeting that criteria. Um, Currently, most of our patients are really motivated to be out of the hospital as quickly as possible, even though we're able to separate where patients who are in the hospital with COVID are from our patients. Patients just generally don't want to be in the hospital right now. We definitely want people to be at home and drinking their fluids. That's where people tend to feel better and do better and get up and move around. But we don't send people home until they meet the criteria for discharge. These are great questions. I'm Sometimes people ask us, what surgery should I have? And I think that is something that is really important to discuss at your initial appointment with me, which we are doing by telehealth, because as we've kind of alluded to with a couple of different questions, um, your underlying medical history, your underlying goals can be so different that it can really vary what surgery is best to get you to that ultimate outcome. Um, Next question is, what kind of anesthesia is used? Well, all of these surgeries are done under general anesthesia. So breathing tube goes in the throat along with gas that's inhaled and medication in the IV, so general anesthesia. Um, After surgery, we want patients to get up and be moving and walking around. Um, and taking lots of deep breaths. Sometimes we'll give patients a spirometer. This was mentioned in the question. Um, that can vary based on your size and your lung capacity. So taking big deep breaths, filling up down to the base of your lungs at least 10 times an hour might make someone cough after surgery a little bit, which is okay. Um, and that spirometer number can vary. Okay, another question. What adverse effects will there be if you don't take your vitamins after sleep? Um, well, while sleeve is mostly a restrictive procedure, because someone's getting less calories and nutrients in overall, they can develop vitamin deficiencies. We can see vitamin D, iron especially we can see with iron deficiencies after a sleeve. That usually happens over time. And so those are more likely to show up when people get out of the habit of taking their vitamins, and they may need iron as a infusion over multiple visits. If people don't get enough B12, they can actually have neurological problems. With duodenal switch, we can see really severe neurologic problems as well. So very important to take vitamins. My general recommendation is to make that part of the habit even before surgery. Um, Putting your vitamins next to something you do every day. So if they go next to your deodorant or next to your cell phone that you pick up before you walk out of the house, or with your car keys, something that you need in your hand every day so that you don't forget them. Sometimes people start by setting an alarm on their phone so that they remember those every day. Okay, uh, have another question. Will the sleeve be enough to fight effects of hysterectomy, menopause, and hypothyroidism? Um, yes and no. So hypothyroidism or low functioning thyroid is something that needs to be dealt with medically with medications. Um, Generally, we don't reverse that with weight loss surgery, although it may become easier to manage. And it definitely needs to be managed well before surgery, or patients may not get the benefits that they're seeking. Um, some of the hormonal changes as women age may slow down weight loss, and so we may not see as much or as quick a weight loss, but certainly our postmenopausal patients have good weight loss benefits and often see their energy levels increase over time as well. Any other questions tonight? Okay. Well, just to recap, I want to say thanks to everyone. Um, Oh, one more question. Would you not perform an ESG if you recommended a VSG? Um, I would not. So ESG, endoscopic sleeve gastroplasty, is considered to be a permanent procedure. So that would only be indicated for someone with a BMI between 30 and 40 with no reflux. Um, Anyone with a BMI over 40 should consider the 3 surgical interventions, whether it's sleeve gastrectomy, gastric bypass, or duodenal switch. And that can be a decision made um, at a consultation in the office or through telehealth to really look at other medical problems and benefits of each surgery based on those other items in the medical history. Um, the it gets a little complicated to give too much advice on that, since we're not, sharing all of those details. So I would encourage everyone that's watching tonight to continue learning more. We would like to see you in the office or through a virtual visit and talk to you about your medical history and what weight loss surgery can do to improve your overall health. And thank you all very much for your interaction in this media here. And thank you for your time this evening. I hope that you all have a very nice Thursday night and stay very safe and healthy. And thank you again for all of your time. It's really nice to virtually meet all of you, and hopefully we'll meet you soon in the real world. Bye.